Dr. Craig Jones serves on the VHC911 Board of Directors and was previously the Executive Director of Vermont Blueprint for Health, Vermont's multi-payer healthcare transformation, focused on advanced community-oriented primary care. He is currently working with Vermont Agency of Human Services, supporting Vermont's healthcare transformation initiatives, including working with hospitals on regional transformation. Dr. Jones has published in a number of journals, served on committees with the National Academy of Medicine, and on the faculty of the Keck School of Medicine at the University of Southern California. Dr. Peter Pronovost, Chief Quality and Clinical Transformation Officer at University Hospitals in Cleveland, is a world-renowned patient safety champion. His work has earned him a MacArthur Genius Grant and a spot on Time Magazine's 100 Most Influential People in the World. At UH, Dr. Pronovost developed a management system to make defects in value visible and deployed a management and accountability system to eliminate those defects. This system reduced the annual cost of care for Medicare patients by 30% over 3 years, while improving quality. In 2022, Dr. Provost led the efforts that culminated in UH winning American Hospital Association's Quest for Quality Prize, the industry's most prestigious honor, recognizing its member organizations for their commitment to quality. Can I invite Craig Jones to take the mic?
First of all, I want to thank everybody for coming today. It's really incredible that so many people made it, take your time out of your day. Everybody's busy. But this is a special opportunity. We're at an inflection point, as you've heard described, in the state. And we have a real opportunity here. And so we wanted to bring special guests here who can talk about how they engineered the change that they engineered. My job is to give a little bit of context. I'm going to make it brief because we want to get to the real showstoppers. This is the chart I believe Governor Douglas was referring to that captured him, so it's probably the best chart that we ever put out. We did a lot of data work, but it makes the point that Governor Douglas made, and it makes another point that I want to start the conversation with. You can see the inflection point. We changed. The rest of the country didn't change the same way. New Hampshire on our border, taking care of a lot of Vermonters, didn't change the same way. Maine didn't change the same way. And yet, the narrative 18 months ago in the state of Vermont was that the reason for our high premium costs was demographics. We're old, we're aging. It was, we are expensive because we're small. We don't have economies, scalable economies. It was Medicare doesn't pay our hospitals fairly, they underpay our hospitals. There was a whole litany of reasons, and we just kind of accepted it all. And that's really what brought 911 together, was say, this is not explained by those factors, we don't think. Let's dig into the data, let's start looking at national data and see what the reasons are. And that's what really brought the coalition together. Well, you can go to the next slide. When we started looking at the data, go ahead, Claudia, punch it down. We put out a lot of different things. I just pulled one slide. I don't want to go through a bunch of information for you, but just wanted to highlight the point. This particular chart shows the ratio of salaries at our hospitals that were going into general services, what it takes to operate a hospital, versus what was going into direct clinical care. This is what it looked like in 2023. Whether you used American Hospital Discharge Data, National NASHB Hospital Cost Tool, no matter how you looked at it, this was the pattern. We can quibble about the numbers, this was the pattern. And what was revealed is that our largest hospital and its network had very high operating costs, and a lot of it was going into management, administration, non-clinical services. And you can look at productivity, and I don't have to highlight that for you because the Green Mountain Care Board's liaison team that worked with UVM Health Network has put out their findings as they dug in deep. And it all pretty much aligned with this type of pattern. But there's also differences here. What we see with the Health Network, Academic Medical Center, and some of our smaller city rural hospitals, which are really important anchors here in Vermont, isn't the same as necessarily with the critical access hospitals, and we have differences. And those are critical in thinking about as we talk about hospital transformation and regionalization of services, and we can get into that later. There's also one other slide I just wanted to highlight for you. What was behind this in addition to high costs? What was really driving the commercial rates? And we looked at it a lot of ways. So this is simply a chart, distribution chart, 2023 data, so it's not current, but at the time, this is how we looked when we looked at our hospitals. Are they making money or losing money on Medicare reimbursement, which is an important theme. And you can see our UVMMC, our largest hospital, over to the right side of this distribution chart. They were losing in that year around $900 million. That's what they reported on the Medicare cost report for that particular year. And then you can see a series of other hospitals along the distribution. The majority of them, not a large majority, but a majority, were making money on Medicare reimbursement at that time. We were clearly doing something different. And it was reflected in what we reported, what our hospitals reported as a loss. The chart I didn't bring is the flip of this, commercial profits in the same year. And on that one, UVMMC is in the top corner. They were number 6 in the United States on commercial profits when you looked at the amount they were making per discharge, all normalized and adjusted. That was the story at the time. As Blue Cross reserves were draining, and as we were entering into an incredible cost crisis. And that's really what drove the 911 work to dig in and produce the data that we have. The good news is, 18 months later, the discussion is entirely different. And we go to the next slide. We've gone from a place of looking at problems and reasons to an opportunity, the purpose of today's discussion. No longer are the same narratives holding, that it's nothing we can do about it, it's our demographics, we're aging, we're old, we're different than everybody else in the country. That's not holding anymore. The legislature, thank you, has passed guiding legislation that's really important. Some of it got signed. We have started initiatives in the state with AHS, including a large array of transformation initiatives that are underway, and I can't say enough how energetically the hospital leadership has engaged with the Agency of Human Services team in working on hospital optimization, improving efficiencies, regionalization. Many of you are here today that work on those things. Thank you, by the way, I really appreciate it. That work is energetic. That is a constructive upward force in terms of trying to build better access, better quality. And it's driven by the guiding legislation that was passed in particularly the last year, but the last 2. On the other side, we have a Green Mountain Care Board and thank you folks for being here, that has changed their approach in the last 2 years and has taken a targeted, focused approach at driving down costs, pushing hard a lever on hospital budgets. It's a blunt instrument, but it was something that had to happen in order to stop what was going on in terms of an uncontrollable fashion. And that paints the opportunity. The market forces aren't even up here. The people that won't buy insurance, how businesses will do, that's not even up here. But these are tangible things going on in the state which are under the control and the influence of you folks who are sitting in this room. We have this balance of pressures, the regulatory pressures, the transformation pressures that are acting right now, and we're at the beginning of it. And so the question is, will we do this right? Will we execute on the opportunities that are here? The many opportunities under transformation are big. These are not small projects, and the Rural Health Transformation Fund is intended to support them in various ways. Will we get it right? Will hospitals be able to respond and work on this as they're under the budget pressures that the Green Mountain Care Board is putting on them simultaneously? Those are difficult conversations. Leadership. That's really what this is about this morning. You can go to the next slide. And that's why we brought the team here to talk to everybody. They've undergone many of these same pressures in a large hospital health system, and they've engineered the balance that we hope we can strike here. So with that, I really want to turn it over to our guest, Dr. Pronovost. This is a summary of some of the work that they've done. It's a really unique leadership style, which has led to the awards and the recognition that they've achieved. But now's a chance for us to really dig in, and I encourage you during the panel, question them hard on the difficult things. Like, I heard you say Medicare money. How much commercial impact did they have? Let's ask them about those things. So while they're here, I want to turn it over. Welcome, Dr. Pronovost, and thank you for being here.
Thank you. So thank you all for joining. It's been great to make friends, and you have just an amazing plan. But before I tell you about our management system and accountability and organizational transformation, I want to tell you about a little girl named Josie King. Josie died from preventable harm in a hospital. Her mother, Sorrel, had every reason to turn towards anger, to hate us. Instead, she turned toward purpose. She challenged us with a simple question: what are you going to do to ensure that this will never happen to another family? That question has followed me, perhaps I'd say haunted me, for more than 2 decades. It followed me as a physician in the care I deliver. It's followed me as a patient safety research and policy person in how we design systems. And it follows me today as a healthcare leader. Because when you strip away all the complexity in healthcare, every metric, every dashboard, every strategic plan eventually leads back to a human being. A patient, a family, a caregiver, someone's Josie. And that realization led me to the very simple conclusion that the biggest challenge we face in healthcare is not reimbursement, it's not cost, it's not workforce shortages. It is simply our greatest challenge is that we have forgotten how to solve complex problems together. And there's a lot of them. And the simple reason is we've forgotten love. And that word may sound jarring, but when I use the word love, I'm not talking about sentimentality. I mean treating every person as worthy of respect and capable of growth, contribution, and excellence. Love says, you matter. Accountability says, because you matter, excellence matters too. Love without accountability is just sentiment. It goes nowhere. Accountability without love just drives fear, and learning stops. We need both. The opposite of love, though, is not hate. The opposite of love is separation. And separation is at the heart of nearly every challenge that we face and why we struggle. When clinicians feel separated from their purpose, when staff feel separated from leadership, when departments feel separated from one another, when patients feel separated from caregivers, when the multiple agencies working on this feel separated from each other in the health systems. You see, when that happens, fear rises, learning slows, and improvement stalls. But when people feel connected, something extraordinary, truly extraordinary happens. They learn, they innovate, they solve problems, and they become capable of things they once thought impossible. And that is exactly what happened when we worked to reduce central line infections that Mark talked about. The checklist mattered. The science mattered. But the real breakthrough of what happened was people stopped believing that harm was inevitable and started believing that harm could be prevented. And they started believing that they were powerful to do something about it. You see, belief changed behavior, behavior changed the outcomes, and outcomes changed lives. That lesson was profound for me because we saw people rise to the level of what we believe about them. When we treat people as worthy and capable, they become worthy and capable in ways that they often never thought possible. That insight led to the foundation of our model of transformation that we call living and leading with love. It has three really simple pieces: believe, belong, and build. Believe that every person is worthy and capable. Belong to a community where every voice matters. Build discipline, management, and accountability systems that convert purpose into performance. Several years ago, university hospitals faced many of the same challenges that you faced. In 2022, we lost $222 million in operating dollars. We had mediocre quality at best. Our turnover was high, our engagement was poor, and we had to do something different. But you see, the issue wasn't a lack of talent. The issue was that we were not fully unleashing the talent that we had, and we had a lot of it. So we committed to believe, belong, build. We connected people to their purpose, everyone at the frontline staff, 35,000 people. We created structures for learning. We built management and shared accountability systems and transparently looked at performance. We moved from fear to learning, from hierarchy to partnership, from compliance to commitment. And the results have been nothing short of remarkable. Operating performance turned around so that this year we now made $55 million from losing 200. We took $600 million out of our operating costs. It wasn't easy. We can talk about later all the things we had to do, but there was waste all over the place, and there's still a ton of waste. Length of stay declined from about 1.67 in our main academic center to now 1.36. That allowed us to increase our admissions and serve our community by about 15% more admissions every year. Our community hospitals now, as all 15 of them, went from an O to E to about 1.4 to 0.98 across all 15 hospitals. Just remarkable performance. We reduced surgical mortality by 70%, surgical complications by 65%. Our net promoter score is 83. It's gone up off the charts. Our patient experience, where we went from one hospital was over the 50th percentile to now, on average, all of our hospitals are at the 85th percentile. Our turnover went from 22% amongst nurses to 12%. Our engagement score went from average to the first percentile in the country. And I can go on. There's like 400 measures. Because when you get this right, it's not one thing that improves, it's everything that improves. Because once you learn how to solve problems, or you get this culture right, it's just a virtuous machine of getting better in ways we never dreamed possible. But the numbers don't tell the whole story. The people tell the story. And I want to share two stories that just highlight the importance of this, especially the belief part. When we started this, we made a decision that the lowest goal we would ever set for our performance measures was the 50th percentile. There's a benchmark. We believe our staff are good. Well, at the time I mentioned, only 15% of our hospitals, one, was above the 50th percentile in patient experience. And the staff revolted, not the staff, the managers, because there was a financial incentive to it. You're setting us up to fail, Peter. This isn't fair. You're abusing the staff. There's no way you're going to improve with this. Like, you have to set it. What we normally do is just have them improve 1% a year. So one of our hospitals was at the 2nd percentile. Another one was at the 8th. And so I said, let me just pause for a second. You can look at it that I'm going to set them up to fail, but I believe our staff are better than the 3rd percentile, way better. And I am not going to tell them that that's what I believe you can perform in. So your job is to work together and set them up to achieve that goal, because our people are at least average. And it was like this transformational moment. We said, no, like, if we're not accepting 3rd percentile, and I mentioned this year, every one of our hospitals are now like above the 70th percentile. But it shows that mindset of the belief, right? People have been so constrained that we have to accept harm as inevitable. Another one of my stories that truly shows the power of this transformation, not just in healthcare, but in people's lives, was an environmental service worker. Part of our rules of belonging is that any project we do, any role that touches the process needs a seat at the table because we genuinely believe they can contribute. And every site of care has to have a voice because if they won't work if we don't fit it to their construct. So we had never included EVS workers on the team before, but we did. And when we first talked to this woman, she wouldn't look us in the eye, I think because we had led her to believe to be ashamed of her roles in EVS. I mean, it's truly profound. She wouldn't look. And she didn't believe that she had much to contribute. But we believed she did. And so we asked for her ideas. And importantly, we listened. And we acted on them authentically. And she began to share some of her beautiful stories. Like one of the things she shared is, and those of you who work in the hospital will get this, cleaning a room, especially after someone has an infection, is really a technical task. And we outsource it to a service provider, but they're training that. She said, I don't really understand how to clean it with that technical. We don't get great training. Our competency wasn't so great, and so we worked with them to make sure we do. And she also had ideas to improving patient experience. And what she shared was profound. She said, Peter, I've been doing this for like 30 years. And I noticed in virtually every patient, when you go in the room, there's some space that is their sacred space that they kind of make home. It's often the nightstand, and if you've been in a hospital, it would have pictures of loved ones, it might have a Bible, it has some artifact that means something to them. And she said, I've learned that you have to honor that sacred space. So I asked permission before I touch it. Some people don't want to touch it, it's theirs. But we said, wow, that is like so beautiful. So we started, training all of our workers on that simple but yet profound concept. Well, I mentioned we're data-driven. So every week we would put rates of infections in patient experience scores. And she took those graphs home and put it on her refrigerator. And she shared them with her family. She had 2 daughters who were struggling in high school and weren't really engaged. But they never asked her about her job, and she never talked. Again, because she saw herself as I clean rooms. But she started sharing with them, look, I'm part of a safety team. I reduce patients' suffering, and they got energized and said, Mom, I want to go into healthcare just like you are so I can, relieve suffering. And she believed she reduces suffering, and she does, and her daughters just became so proud of her. Now, I want you just to pause and think about what I just shared for you. A management system that changed a family's future, right? Because someone helped someone believe another human could discover their purpose, right? Simply believing that people are worthy and capable. That is the power of believe. That is the power of belong. That is the power of building. And that is the power of this transformation model. Because loving doesn't lower our standards. Loving raises our standards because it raises people. And when people feel valued, they speak up. And when they speak up, problems surface. And when problems surface, improvement follows rapidly in this culture. So this isn't some magic formula. It is literally everyone in the organization feels worthy, they speak up, you solve problems. And I mentioned our biggest problems is not knowing how to solve these complex problems. And we have a whole 35,000 people engaged. And that is why this Living and Leading with Love is not simply a culture initiative. It is a framework for solving complex problems. It is a framework to truly create a learning organization and health system. And most importantly, it's a framework for unlocking human potential. As I think about this work that we do and your moment here, in every collective human endeavor, there comes a moment when the noise quiets, a moment when individual values become aligned around a common purpose, a moment when we know so much more about what to do than we may have admitted, and a moment when what once seemed impossible suddenly becomes achievable if you choose to act together. I believe Vermont is standing in that moment today, this morning. You have extraordinary physicians, extraordinary nurses, extraordinary caregivers, extraordinary public service, extraordinary communities. You have all the knowledge that you need. The plan that Craig showed is brilliant. It's transformative. You have the talent, You have the resources, you have the values, you have everything you need. But what remains, and it's crucial, is a decision. A decision about whether you will continue to operate in separate interests, each protecting your own corner of the system, or whether you will come together around something larger than yourselves. I think John F. Kennedy said it best when he said, "United, there is little we cannot do in a host of cooperative adventures. Divided, there is little we can do." So the question before Vermont is not whether change is coming. It needs to. It is whether Vermont will lead. The question is not whether healthcare could be better. We already know it can. The question is whether we will have the courage to build it together. Living and leading with love is not a program. It's a choice. It's a choice to believe that every person is worthy and capable. A choice to belong to something larger than ourselves. A choice to build systems that transform good intentions into extraordinary outcomes. And if Vermont makes that choice, something remarkable can happen. You can become more than a state trying to solve its healthcare challenges. You can become a model for the nation. A place that proves healthcare could be high quality, affordable, accessible, compassionate, and sustainable. A place that proves collaboration is stronger than competition. A place that proves that love is not soft. It is the most powerful force for solving complex problems. Because the future isn't decided, it is created. And sitting in this room today are the people who can create it. The choice is yours. You can continue to be shaped by the future, or together you can shape the future for the rest of the country. Small states have often changed the course of history because they could move where others were not able to. Vermont now has the huge potential to show America that healthcare can once again be organized around people, purpose, and love. Not because Vermont is the biggest state, not because you have the most resources, but because Vermont has something even more powerful. The ability to bring people together around a common purpose, just like you're all here today. Years from now, America's still going to be facing the question every community faces today. How do we create a healthcare system that is more affordable, more compassionate, more effective, and more human? Vermont can answer that question. Vermont can become the proof that caregivers, patients, universities, employers, communities, and government can work together, and when they do, extraordinary things become possible. And if that happens, people will not remember this as a meeting. They will remember it as a beginning, perhaps an inflection point. The moment the state stopped deciding to waiting for the future and started creating it today. The moment leaders chose courage over comfort, collaboration over division, and possibility over cynicism. The movement of Vermont showed the nation what is possible when people believe in one another, belong to one another, and build together. Because in the end, the greatest measure of leadership is not what we preserve, it is what we create. And if we create this together, Vermont will not simply improve healthcare. Vermont will provide the needed message to America of what we can be. And there is no greater legacy that you can leave than that. Thank you.